Greetings, everybody. My name is Ivatury. I'm a professor emeritus in surgery in Virginia Commonwealth University in Richmond, Virginia, in the United States. It's a great privilege for me to be here for this International Symposium of Critical Medicine. And thank Jaime for inviting me to speak at this symposium. I was asked to talk about penetrating trauma, and I chose to talk about this optimal resuscitation of the injured patient in extremis. I will review for you the current concepts of resuscitation of the unstable trauma patient in extremis. I have declared that I have no conflict of interest. It is very important to keep in mind that the recognition of instability is an important component of approaching these difficult patients. Remember that these patients may have a compensated shock, so they may look all right, but in effect, they are in severe hemorrhagic shock. So it is very important to recognize the state, promptly transport them to the trauma center, do a prompt and complete assessment and intervention in all these areas for optimal results. Really, the pre-hospital period where the scene of injury is really the ground zero of controlling this damage. This damage control, as you know, is a naval term that came from taking the ships that are injured back to the base so that they can still function while getting repairs done. So that is our approach for these difficult patients. In ground zero, the paramedics do a very rapid assessment of the airway, breathing, and circulation. It's most important that they scoop and run with this patient. That means that not to waste time at the scene trying to stabilize these patients, but to take them immediately to the trauma center and the resuscitation areas, so a definitive treatment in terms of resuscitating these patients can take place. What they can do at the scene to stop the bleeding, they can do. In other words, they can put in a tourniquet, they can put some compressive dressings if they recognize the site of bleeding. But for non-compressible areas of hemorrhage, such as the chest or the abdomen, what they really have to do is do a prompt export of the patient to the trauma bay. There was a lot of controversy in the past about whether to resuscitate these patients at the scene or not. Back from 1918, Walter Cannon actually pointed out that if you have inaccessible or uncontrolled source of blood loss, there is no really point any treating these patients with intravenous fluids, because all that will do is to raise the blood pressure and blow out the clot that is trying to control the bleeding and make the things worse. And this lesson has been learned repeatedly. Shafton commented on the same thing in 1964, and only recently we began to appreciate the wisdom of this approach. So hypotensive resuscitation aims at maintaining a pressure of 60 to 80 and not increase this mean arterial pressure so that we do not dislodge the clot that is preventing the bleeding. And this is especially true for patients with penetrating trauma who have a known source of hemorrhage that needs immediate operative control. There is very good experimental evidence, but not less clear clinical evidence for supporting this hypothesis. But more and more people believe that this is important, especially in penetrating trauma with a short inner city transit times of less than 15-20 minutes. The optimal mean arterial pressure that is ideal is a source of controversy, but most likely is around 60 to 70 millimeters of mercury. Now, in 2021, we begin to talk about pre-hospital use of not just crystalloids, but also of blood, plasma, and so-called tranexamic acid. And I'll give you some recent data on this. And this is a recent series that came from a multi-center randomized controlled trial of crystalloids versus thawed plasma in air transport patients who have a transit times about 25 to 30 minutes, probably not an inner city trauma, but a rural trauma. And this series showed that the pre-hospital administration of thawed plasma actually resulted in a lower mortality, 30-day mortality, than standard care resuscitation with ringer's lactate. And this is hot off the press in 2021 March. The same authors did a secondary analysis of their patients. 417 patients actually showed that packed red blood cell transfusion plus plasma had the greatest mortality benefit, followed by plasma alone, followed by packed red blood cells alone, and then only crystalloids. So if you have the opportunity and the privilege of getting plasma and packed red blood cells at the scene in transit and is a air transport, then you can try and attempt this. What about tranexamic acid to prevent fibrinolysis? There have been again multiple studies on this, but there is no complete consensus on the reduction in mortality. Especially important that this has to be given within 3 hours after injury. Otherwise, actually, it increases fibrinolysis and actually increases mortality. So once you reach the emergency department, once again, the damage control principles are, if you have a moribund patient, as we are talking about today, these patients should have an emergency department thoracotomy immediately, especially if they are at the risk of having a cardiac arrest, and have an aortic cross clamping to prevent further deterioration of the hemodynamic status. Now, more recently, this is a resuscitative endovascular balloon occlusion of the aorta has become very prominent, especially if you have major trauma centers such as in Cali, Cartagena, Colombia, where you have an established endovascular team that can come into the emergency department or the operating room and introduce a sheath via the common femoral artery and have a balloon occlusion of the aorta to maintain this blood pressure around 70 millimeters of mercury. For proximal control, this actually will diminish the amount of bleeding that is happening from the abdominal or pelvic injuries or the extremity injuries. Controversial in terms of thoracic injuries, but Carlos Ordonez from Colombia actually has shown that it can be effective in those circumstances also. But most certainly it's very useful for abdominal pelvic injuries where we have proximal control, maintaining the blood pressure till you have definitive control of the bleeding. Now, damage control is all about stopping the bleeding, and that is the priority at this time. So patients should be taken immediately to the operating room, have an emergency laparotomy or thoracotomy, exposure of the bleeding vessels, and attempts at stopping the bleeding. In terms of solid organ injuries, this may require not only controlling the arterial hemorrhage, but also to control the secondary hemorrhage that is non-surgical because of coagulopathy. So these patients should have an abdominal packing. And at this time, all we need to do is to control the bleeding as best as you can, control of contamination and bowel injuries by rapid closure of these holes in the intestines. And this is no time for reconstruction. This is no time for doing anastomosis. This is a time for controlling the bleeding and taking the patient out of the cold operating room to an intensive care unit for further resuscitation. The abdomen can be closed rapidly by any of these temporary measures, such as your mesh or rapid application of towel clips, or as you know, by the Bogota bag. Always think about these interventional radiologists that can actually control some of these bleeding that are intrahepatic or intraparenchymal in the liver or the spleen or other organs by non-invasive, minimally invasive techniques such as interventional radiology and plugging these holes. Now we have progressed towards damage control resuscitation from damage control surgery. And our goals are to correct acidosis, correct hypocalcemia, correct hypothermia, and also do multiple transfusions of the RBCs and coagulation factors. And we'll expand on this a little bit more. It is very easy to control acidosis and hypothermia, but it's not so easy to control coagulopathy. And this has been an area of intense research. And for a long time, about 20 years now, we knew that actually the coagulopathy is very extremely soon after onset after injury. And the initial INR that is more than 1.5 increases the mortality tremendously, especially military casualties. And patients who have a significant injury also present in a significant coagulopathy And the severity of injury and mortality is linearly proportional to the extent of injury and the coagulopathy. And this graph will show you the derangements in coagulation that occur rapidly after trauma. The more the ISS or injury severity, the more the incidence with coagulopathy. And the percent of mortality goes up as we have patients with coagulopathy and without coagulopathy in a linear fashion. And this has been experienced with multiple civilian trauma centers as well. You can see that patients who are coagulopathic on admission to the emergency department or the operating room is a very high incidence of coagulopathy on admission, 28% to 47%. And these are the various risk factors for coagulopathy, which we all understand: acidosis, hypothermia, increasing injury severity, and hypotension. So these patients are candidates for multiple massive transfusion protocols where you try to give a higher ratio of RBCs and fresh frozen plasma as clotting factors. And multiple studies have shown this, that the lower ratios have a lower incidence of survival. As you become to 1:1 or 1:2 ratios of packed red blood cells and plasma, the survival goes up and improves dramatically. And this is the trauma outcomes group data from Dr. Holcomb and Associates. Actually, our center also was a participant in this multi-institutional studies. There were 16 level 1 trauma centers, an additional 6 centers, 643 patients who got more than 10 units of RBCs. And if you look at the 6-hour, 24-hour, and 30-day survival, it is much higher in those groups who received more fresh frozen plasma and packed red blood cell ratios and platelets. More recently, the thromboelastography has really become very useful for us. And this can be done as a point care testing. It can really provide data within minutes, and it allows a complete assessment of coagulation and fibrinolysis in about 90 minutes. And this is how the thromboelastogram looks like. And this is the activating clotting time. This MA shows the platelet function. So in these studies, activated clotting time indicates the speed of the initiation and propagation of the coagulation cascade. Now, this is prolonged, it is suggesting to you that this patient has a consumption coagulopathy or a dilutional coagulopathy. So these patients require immediate fresh frozen plasma. On the other hand, the MA, or the maximum amplitude of the TEG, is showing some abnormality. That means that the platelets are not enough or not working properly, and these patients would need additional transfusions of platelets. So this becomes an important goal-directed therapy for this coagulopathy. And I'm sure that in a few years now, we will see the results of this application of thromboelastography and perhaps improved survival in these very sick patients. The last component that's very, very important is what we have learned recently. And that is the restriction of crystalloid overloading. And this is a series that looked at goal-directed therapy, giving only crystalloids as much as necessary to maintain mean arterial pressure and to correct the acidosis. And these patients in this group, as compared to a conventional resuscitation group, had low risk of pneumonia, low risk of kidney complications, and a shorter length of hospital stay. And this is Dr. Von Deschesny's data. We showed that in the damage control surgery and conventional resuscitation, and this is damage control and damage control resuscitation with crystalloid restriction. And they showed that the ICU length of stay is much lower in this group as compared to conventional resuscitation. The survival is much improved in this group as compared to conventional resuscitation. So it's very important to not overload these patients with crystalloids. That's going to work against us. Very important also in this ICU to completely resuscitate these patients. And most importantly, prevent the second hit that can happen to these patients These patients have been through an ischemia reperfusion injury with all the hemorrhagic shock and resuscitation. And if they have a second hit in terms of ICU complications, such as infections, such as intra-abdominal hypertension, we'll talk about in a minute, these patients will go into severe multi-organ dysfunction syndrome, and their survival goes down tremendously. It's also very important that if you remember that these patients have a temporary closure of the abdomen, and thus abdomen needs to be closed as early as possible with your negative pressure wound therapy techniques, such as Zaptera, that allows all this intraperitoneal fluid to be evacuated, keeps the intra-abdominal pressure down, allows you to close the abdomen and fascia rapidly within the first 7 to 10 days by repeated visits to the operating room and repeated attempts at closure of this abdomen. It's a very important concept. The more the abdomen is open, the more the complications are, and the more the chances for multi-organ dysfunction. And finally, we are very, very strong in believing that we have to really worry about the intra-abdominal pressure. If you let the intra-abdominal pressure go up, the so-called intra-abdominal hypertension, this has a profound effect on the splanchnic bed. The ischemia, the reperfusion injury, and the IIH are additive, and this causes a systemic inflammatory severe challenges that can serve as the second hit for these developments, who can then go into development of multi-organ dysfunction. So it's a morbid complication that increases mortality. You have to worry about that by recognizing that these patients need a close monitoring of the intra-abdominal pressure and keeping the pressure down below 15 centimeters of water so that they don't get into intra-abdominal hypertension. Now, uncorrected, this intra-abdominal hypertension will go on to lead to abdominal compartment syndrome and multiple organ failure, and that has a tremendously high mortality. So you need to keep that in mind. So in summary and conclusion, damage control surgery has led to recently damage control resuscitation, which is a more physiologic approach to these very sick patients with very strong hemostatic endpoints in 2020. So we must recognize the need for massive transfusion, have a massive transfusion protocols. You must think about permissive hypotension, not to give the patient too many fluids before you control the bleeding. Try to control the bleeding as rapidly, as efficiently as you can, using all the techniques that you have available, including surgical, interventional radiology, packing, etc. Don't forget about these high ratios of packed cells to fresh frozen plasma, because this will prevent or diminish the amount of coagulopathy and lessen this non-surgical bleeding. Always think about the thromboelastogram as a very important component for you to determine what exactly in the coagulation cascade that we need to correct, whether it is the fresh frozen plasma and its components, or whether it is the platelets. And finally, most important, you always should restrict crystalloids, not overload the tissue with crystalloids, and give the fluids only as much as the patient needs in terms of the hemoglobins, packed red blood cells, etc. And finally, with good, excellent critical care, worrying about intra-abdominal pressure, worrying about surgical nutrition, these patients will have optimal results. So these are some of the things that you need to keep in mind for optimal resuscitation of these very sick, very critically injured patients. So thank you very much for your attention, and thank you very much for the privilege of participating in this symposium.